All right, welcome, welcome. Well, let's go. I can see some folks still coming in, but I want to be mindful of everyone's time today. So we'll go ahead and get started. I know we are recording this, obviously. So welcome again. Thank you for joining us today for our public forum from screening to solutions in gestational diabetes diagnostics. I'm Katie Schubert. I'm president and CEO of the Society for Women's Health Research, which is a national nonprofit dedicated to advancing women's health through science, policy, and education while promoting research on sex differences to optimize the health of women. Modern diagnostics, from basic labs to imaging and procedures, are essential for detecting and monitoring disease and guiding treatment. Innovations in diagnostics can equip women with the information they need to make informed health decisions at every stage of life. And as part of SWHR's Value of Diagnostics within Women's Health series, an area I would note is something that's very exciting, but also something that we really want to make sure that we're highlighting regularly. We are highlighting the importance of advances in screening and diagnostic technologies and approaches throughout the lifespan, with a focus on how we can improve health outcomes for women. And our theme for 2025 is maternal health. We're pleased to have our panelists joining us for today's public forum in recognition of National Diabetes Month. Dr. Mesa Fagali, Associate Professor, Department of Obstetrics and Gynecology at the University of Pittsburgh Magee Women's Research Institute. I'd also like to thank the sponsor of today's event, Roche Diagnostics, and note that SWHR maintains independence and editorial control of our program development, content, and work products. As always, we are live tweeting this event and we invite you to join us. Please use the hashtags SWHR Talks Diagnostics and SWHR Talks Maternal Health on all of our social media channels. And at this time, I'd like to introduce SWHR Science Programs Manager, Serene Gulmamine, who's moderating today's fireside chat. So, Serene, take it away.
Thank you, Katie, and welcome everyone. Gestational diabetes, also known as GDM, is a condition that occurs when blood sugar levels become too high during pregnancy. It develops when the body can't effectively manage glucose, also known as blood sugar, leading to elevated levels that require monitoring and care for both mother and baby. The International Diabetes Federation has published that 1 in 6 live births had a gestational diabetes diagnosis worldwide. In addition, gestational diabetes affects between 2 to 10% of pregnancies in the US and is typically diagnosed between the 24th and 28th weeks of pregnancy. A GDM diagnosis may increase one's chance of developing preeclampsia or having a cesarean section, and it can also have lasting impacts as well, posing nearly a 50% increased risk of developing type 2 diabetes within 5 years of a GDM diagnosed pregnancy. The benefits of identifying GDM have long been established, particularly in that early GDM treatment can help reduce adverse pregnancy outcomes. Today's public forum will explore the impacts of gestational diabetes on women's health and the latest advances and gaps in screening and risk prediction. I'll now introduce Dr. Maisha Vagali to talk about the impacts of gestational diabetes on women, including disparities in disease burden and preventative care, as well as innovations and gaps in diagnostics. As a reminder, please feel free to submit questions using the Q&A function for us to address during the portion of that webinar. Thank you for joining us.
Thank you, Serene, and thank you everybody for joining today. Just want to confirm that you can see my slides. Then we'll go ahead and get started.
Yep, we can see them.
Excellent. Well, I'm delighted today to be talking about from screening to solutions in gestational diabetes diagnostics. As Serene mentioned, gestational diabetes is a condition that is specific to pregnancy, where high blood sugar or hyperglycemia is first noted. And in the US, it seems to impact about 500,000 people every year. It is a combination of metabolic changes that predate pregnancy, as well as pregnancy-specific changes related to the placenta. Some of the changes that the placenta causes are an increase in insulin resistance. And even though insulin secretion increases in pregnancy, that increase is not enough to normalize glucose metabolism, and that level of hyperglycemia in mom's blood sugar seems to be related to adverse pregnancy outcomes. And if you were to think about gestational diabetes, I want to invite you to sort of think of it along the spectrum of somewhere between a kind of impaired glucose tolerance and type 2 diabetes. Think of it as a milder form of type 2 diabetes. Some of the things related to type 2 diabetes can be paralleled in gestational diabetes, and then some other aspects that we're going to talk about a little bit later are somewhat unique to this condition. The reason why we care about gestational diabetes is to really try to decrease maternal morbidity. As Serene mentioned, there's a higher rate of preeclampsia associated with gestational diabetes, a higher rate of cesarean delivery, and even in the absence of those things, a higher rate of traumatic birth occurring and impacting moms. We know that there's also a significant risk of type 2 diabetes, and given the engagement that pregnant individuals have during their pregnancy, it may be an opportunity to try to prevent long-term complications as well. The current diagnostic approach for gestational diabetes in the US is a two-step approach. It usually occurs between 24 to 28 weeks of pregnancy. It starts off with a screening test, which is a 1-hour oral glucose challenge test, whereby the individual will essentially drink a solution that has a standard 50-gram oral glucose load, and then a blood sugar is measured 1 hour later. And that individual, if the level is higher than 135, is considered to be screen positive. And then they move on to the diagnostic test, which is a 3-hour oral glucose tolerance test, where a fasting blood glucose level followed by a 1, 2, and a 3-hour sample are collected after a 100-gram standardized oral glucose solution. And individuals are diagnosed with gestational diabetes if 2 or more values are elevated. Over the past few years, we've seen a significant increase in GDM incidence in the US. In 2016, the rate was about 6%. The rate is approaching 8% now, impacting at least 1 in 12 pregnancies. And there are certain situations where lower glucose thresholds have been considered. And in that setting, as high as 20% of individuals in the US would meet the criteria for gestational diabetes. So it's certainly an increasing problem that is occurring in the US. But part of the problem relating to current diagnostic and screening approaches is that it is quite burdensome. For the most part, it still involves the patient coming in and doing 2 tests. It can result in delays in care because that 3-hour test that I mentioned is a fasting test. It is a lengthy test. It often has to be scheduled ahead of time. There are very few places that allow for it to be a walk-in test. And so oftentimes after individuals get a screen positive test, it can be a couple of weeks before we are able to know what their GDM status is. Another criticism of current diagnostic approaches is that essentially it was not designed to identify individuals at increased risk for adverse pregnancy outcomes, but the cutoffs that were defined for diagnosing gestational diabetes were really focusing on individuals who are at higher risk of developing type 2 diabetes after pregnancy. And so knowing that this is a test that is being done in the setting of pregnancy and given the association with adverse pregnancy outcomes, it is quite significant that this test is really designed for longer-term risk prevention or risk assessment. Yet, even with all those criticisms, screening does appear to improve outcomes because we know that after we find out that an individual has gestational diabetes, treating maternal hyperglycemia is beneficial in decreasing the risk of adverse pregnancy outcomes. And given the benefits of treatment, those have been extrapolated to having a benefit of screening. We know that part of what happened in that setting, given the relationship between maternal glycemia and glucose association with adverse pregnancy outcomes, that had a consequence of leading to tighter diagnostic criteria with lower glucose threshold. As I mentioned, that resulted in a higher rate of GDM up to 20%, but really no improvement in maternal outcomes with the stricter control. And that to us suggested that even though the link between hyperglycemia and pregnancy outcomes was very strong, it may not be as simple as just making it so that we are targeting milder and milder cases by decreasing the glucose threshold. There are certainly quite a few advances that have happened in screening and in prediction when it comes to gestational diabetes, but quite a few limitations. I mentioned the association between maternal glucose, and that association is linear, meaning that there is not any clear cutoffs that would suggest that we are able to categorize an individual as being low risk or high risk for certain pregnancy outcomes. And that certainly was evident whenever the cutoffs were changed or attempted to be changed. It ended up with increasing the rate of gestational diabetes diagnosis, the increase in the rate of treatment, but really no improvement in pregnancy outcomes of interest, including preeclampsia and cesarean delivery. There are other attempts that have really focused on looking at other glycemic markers. Certainly outside of pregnancy, there is actually less and less use of oral glucose tolerance testing. Most frequently, there is a use of glycemic markers like hemoglobin A1C, which reflects kind of individual glycemic levels over the course of 3 months. But in the setting of pregnancy, those glycemic markers seem to have very little utility. When it comes to hemoglobin A1C, the challenge there when it comes to pregnancy is that the hyperglycemia noted in pregnancy and gestational diabetes is quite mild and it's quite short-lived, and it's often not captured within that measure. And then there are certain changes in red blood cell turnover that make it so that the hemoglobin is more short-lived compared to outside of pregnancy, and it doesn't allow for the hemoglobin A1C level for the glucose to attach to that hemoglobin in a meaningful enough way that it can be captured over a hemoglobin A1C. So it's not uncommon for us to have normal HbA1c levels in pregnancy of, say, 5%. And then when you get an oral glucose tolerance test, you can have a 1 or 2 hour value that exceeds 200. Now, given that variation, a lot of effort recently has tried to focus on continuous glucose monitoring as a way of trying to overcome some of the burdens of oral glucose tolerance testing and to try to minimize the lack of utility from glycemic markers, as I mentioned, hemoglobin A1C. And there are early studies that have shown that there may be an association between certain glycemic profiles and gestational diabetes. CGMs are certainly low burden when it comes to patients and quite favored by them as compared to OGTTs. But there is very little data at this point about significant benefit of predicting gestational diabetes or predicting individual outcomes with CGM. And I'm sure that there will be more data to come to highlight the potential benefit or utility of that technology. In fact, while I mentioned that there is benefit relating to treatment, when we looked at our own data quite a few years ago when I was training here at McGee, we noticed that even though the data from randomized trials that looked at treating mild gestational diabetes in a single center hospital here in a contemporaneous cohort, we still had very significant poor maternal outcomes, specifically relating to very high rates of cesarean delivery and high rates of preeclampsia, despite centralization of care, a high level of care, and availability of maternal fetal medicine and certified diabetes educators for all patients getting care here. And part of the reason is that I would like to invite you to think of gestational diabetes as not being a single diagnosis, but having significant heterogeneity and variety. We know that there is quite significant variation when it comes to incidence of gestational diabetes by certain patient characteristics. And here I highlight the variation in the rates of gestational diabetes between non-Hispanic Asian pregnant individuals and non-Hispanic white individuals. And we certainly see that variation in incidence also be reflected in differences in treatment response and then risk relating to pregnancy outcomes. There's variation when it comes to age, with more than 1 in 7 pregnant individuals at or above the age of 40 being diagnosed with GDM as compared to only 1 in 14. And again, we see differences when it comes to pregnancy outcomes by maternal age. And lastly, we see a lot of variation in GDM incidence by pre-pregnancy body mass index, with 1 in 8 individuals who meet the criteria for obese BMI being diagnosed with gestational diabetes as compared to 1 in 22. And again, here by BMI, we see variation in treatment needs as well as pregnancy outcomes impacting individuals diagnosed with GDM. And so we've seen rates of GDM increasing. We also see significant disparities in the rates that GDM is increasing. GDM is increasing at different rates when it comes to maternal age, when it comes to individual self-reported ethnicity and race. We also see variations when it comes to disparities in diabetes between a rural and an urban setting, with a much higher burden in rural settings in the US. And then finally, we see disparities in adverse pregnancy outcomes and maternal outcomes. I mentioned earlier some of the patient characteristics. This is a slide that's really highlighting the variations in pregnancy outcomes, specifically cesarean delivery and preeclampsia or gestational hypertension, that's broken down by self-reported race and ethnicity. And we see a much higher burden in individuals who self-identify as being Black as compared to individuals who identify as being white. And specifically when it comes to panel C in this slide, I invite you to look at how individuals who self-identify as Asian or Pacific Islanders have a very much lower rate of preeclampsia or gestational hypertension as compared to all other individuals. And part of the reason why we think that there is quite significant variation is because gestational diabetes results from probably the broad spectrum of metabolic abnormalities that characterize diabetes outside of pregnancy. And a lot of our focus is really on the imbalance between insulin secretion, insulin resistance that lead to hyperglycemia, but there are probably a lot of different paths to get to maternal hyperglycemia. And at this point, the diagnosis, the treatment, the focus relating to gestational diabetes is very much tied to maternal glycemia. But I'm starting to think that maybe we need to think outside of that box to be able to address the increasing rise in gestational diabetes and to be able to address some of the diagnostic limitations, the risk prediction, and then the variations that we see impacting our patient population. And with that, I'd like to thank you, and I look forward to answering any questions.
Thank you, Dr. Fagali. Please note that those who are tuned in live can submit questions at any time while we're doing our Q&A session, and we'll try to address as many as we can during the remaining time. Also, our conversation today is intended for educational purposes and is not intended or implied to serve as a substitute for personal, medical, or professional advice. We encourage all patients and consumers to confirm information and consult their healthcare providers to determine their individual needs. And so with that, to open our conversation, I'd like to start kind of after hearing the presentation today, what do you see as the most urgent challenge in gestational diabetes care right now? Is it awareness, diagnostics, or the long-term follow-up?
So I think there are two things that I think are highly urgent. I think one is the diagnostics. I think certainly what we know at a population level, we know that there is this link between maternal glucose and adverse pregnancy outcomes. But from the point of view of actual individual care, we have very limited ability to actually provide advice about risk prediction, individual risk prediction, to help tailor treatment and be able to not necessarily just treatment from the point of view of medications versus not, but to be able to understand what the individual risk is, to be able to benefit the patients and inform them so that they can seek the level of care that is most appropriate. And I think in that setting, it may be helpful to think along the lines of not just focusing on more data of glucose. I think right now our approach is, or has been, thinking about different thresholds, thinking about milder forms of gestational diabetes, sometimes thinking about diabetes screening earlier in pregnancy. But those approaches have not really proven themselves to increase our understanding of individual risk or to even benefit populations at a study level. And so I think there's an urgency to think outside of the glucose box. And I know that, there is this push of increasing technology when it comes to glucose data capture with a lot of different models of continuous glucose monitoring. And I know that patients really appreciate that compared to the burden of either oral glucose tolerance testing or self-monitoring at home. And I don't want to discount that in any way. But I worry that getting more glucose data may not actually necessarily benefit us. I think we need to think outside the glucose box and look at other markers relating to individual risk prediction to kind of respond to the second point. You mentioned something earlier, certainly longer term. We know is another thing to focus on. We know that patients in pregnancy are very much motivated to seek care. When we talk about recommendations for universal GDM screening in pregnancy, our rates here at the University of Pittsburgh exceed 96%. And the reason for that is we know that patients want to do the best and are motivated to sort of follow through with medical recommendations,
Thank
especially
you so
whenever we're
much.
talking about risks
That's
related to
that's
their
perfect.
baby.
Yeah.
And so in that setting,
Back of it.
I would want to try to kind of find ways of looking to inform our individual risk prediction when it comes to long-term risks. Because right now we talk about that 50% risk. That's over a period of time of 15 years. And in that setting, it gets very hard to be able to maintain a focus on individual risk. And a lot of times, our new moms are thinking more so about their kids, about their family health, and they forget about their individual risk relating to long-term type 2 diabetes, which can certainly impact them very significantly.
Yeah, I think you touched on some pretty important points in that, particularly thinking about, gestational diabetes outside of just the glucose or the blood sugar levels, blood sugar numbers, right? And the you touched a little bit on the biomarkers and whatnot, but I'm really interested in the data that you showed with the racial and ethnic disparities, the rural versus urban, and would love to hear, aside, we've seen similar patterns. What kind of systemic factors do you think contribute to those parallel disparities across both conditions, and how the role of, I guess, the clinicians, what their role is, I think, in that.
Yeah, so a lot of times it's related to some of the things that I think influence these disparities and outcomes are very much related to just like general health maintenance and preventative public health, more so that interventions at the level of the pregnancy. I think the measures that we see is that oftentimes there is significant association between gestational diabetes disparities and deprivation indices, measures relating to walkability of a neighborhood, availability of quote unquote healthier food sources within a mile of individuals' homes. And so the challenge that we have there is that the diagnostics and the risk predictions oftentimes do not address any and all of that. Even with a measure like BMI, we find that there is significant differences in the performance of BMI as risk prediction when it comes to treatment response in different settings. And so I think it's as a first step, it's important to be understanding that these disparities exist and that these differences need to be accounted for in a thoughtful way whenever there's research that's being done to try to be able to get to a better understanding of the performance of different diagnostics or treatment approaches and risk prediction so that that can be applied to not just a study population that is heterogeneous, but that actually understands some of the differences, the background differences in these subgroups to help us understand how to utilize these measures clinically.
Sure. We have a question from the Q&A that kind of touches on some of the points you've mentioned, but what counseling intervention strategies do you take for women during childbearing years?
Very few. So unfortunately, one of the biggest limitations that we have is the feeling that while we are testing for gestational diabetes in pregnancy and while people are very motivated for it, the seeds related to gestational diabetes we think are often implanted right even before a pregnancy is initiated. We know that a pregnant individual's history coming into pregnancy is actually quite predictive of their own risk of gestational diabetes. So beyond the data from the oral glucose tolerance test, knowing some of the things that lead to disparities, but also some of the things that can be very informative include age, BMI, ethnicity, and that's the challenge that we have there is oftentimes individuals who are of reproductive age, especially younger age, are the ones who do not engage with health systems for anything other than family planning for the most part, or potentially STI testing. And in that setting, there is a lack of education and communication about ways to promote a healthy future reproductive potential when it comes to being pregnant or lessening the risk of pregnancy adverse outcomes. But unfortunately, there's very limited, very few conversations that I've had in my life, and that have focused on that.
Yeah, I have heard a lot, at least from the patient advocate level, that, that some of these things are really, in order to access care, the burden of trying to like manage the, surveillance systems that may exist and just kind of, I guess to that point, because some of these tests are burdensome to patients, right? Whether that's the two-step GDM test, or, the preeclampsia surveillance that exists. How can we reduce diagnostic fatigue while still ensuring adequate surveillance for high-risk patients?
Yeah, I think that the part of the efforts right now has really focused on looking at leveraging continuous glucose monitoring technologies and being able to potentially predict an individual's risk of gestational diabetes in the hopes that that could be applied during a prenatal visit, and the patient can wear it for 7 to 10 days, and then they can return it by mail so that they don't have to worry about another visit or a timed visit in any way, and that that data can be analyzed and their individual risk can be predicted. I think that's potential, that ability to do some form of home testing in their own environment rather than the standard test with a standard solution given in an artificial lab environment is a thoughtful way of going about it. My concern is that that just gives us more glucose data and nothing else. And that's the one thing that I'm continuing to think about, ways of leveraging that modality of testing, but potentially thinking about other markers that can be tested for within that setting so as to not increase the burden, but that can provide a kind of more thoughtful measurement of metabolism beyond just more glucose data.
Yeah, definitely. We have another Q&A that someone mentioned with regards to the 2-hour testing. What does that follow-up look like for patients?
Yeah, so previously the standard had been for individuals who were diagnosed with gestational diabetes to be recommended a 2-hour oral glucose tolerance test, generally done at least 3 months after delivery to try to eliminate all that red blood cell turnover that I mentioned earlier, as well as to try to overcome a lot of the pregnancy-related changes, placenta-mediated changes that lead to insulin resistance, and then do the test to assess for type 2 diabetes. And that recommendation is usually to follow that up depending on the values every year, every 2 to 3 years with their PCP. That strategy essentially captured only 15% of patients who had gestational diabetes because I think, as we mentioned earlier, the OGTT in pregnancy is burdensome. The OGTT with a 3 to 6 month old is another level of impossibleness to sort of expect of patients. And so there were studies that were done to look at administering the OGTT in the hospital prior to individuals being discharged. And the uptake there was over 90%. And in that setting, you might miss some milder cases of prediabetes, but that approach seems to really capture the most significant hyperglycemic patients to try to engage with a care that would benefit them to really try to prevent them from having unrecognized hyperglycemia that goes on longer term. And that was very much favored by patients because patients were in the hospital recovering. And so they appreciated, they didn't want to do another test, but they appreciated not having to come back with an infant trying to navigate that.
Yeah, definitely. We're seeing a lot of things about new technologies coming out and your point about like, while we don't want to discount those, that there are other things that we should also be considering is a very important piece. But we've really seen a lot of people talking about AI and they're interested in AI. And so I'm just curious, as a practitioner, as a researcher, how can AI be leveraged safely and effectively to diagnose patients sooner, and more accurately?
And so I think this is where potentially some aspects of machine learning may be helpful in being able to um, sort of anticipate what future patterns may look like based on current patterns. And so this is where I don't know that current models have the capacity to do that, but I can imagine more advanced computational models whereby you're able to present current data, say at 24 weeks, and to have that be analyzed in a more meaningful way to reflect what the next 4 weeks looks like and help that guide interventions in a more meaningful way. Because right now, the strategy to treat gestational diabetes is very retrospective. And what I mean by that is when patients present their blood sugar data to be reviewed, and we review blood sugar data every single week, the treatment adjustments that we do are reflective of last week's pathology, not the upcoming week's pathology. And so it almost always feels like you are running behind the ball, you're behind the target, and you're not really able to anticipate what changes are going to look like. My sort of hope would be that we could leverage more advanced computational capacity to sort of predict what future patterns could look like based on current data, which we have a much more limited ability to do right now.
Yeah. You saying that, with the retrospective piece of it, I know there are a lot of individuals who see a lot of different care practitioners in their, pregnancy journey, and also just maybe if they have chronic diseases prior to pregnancy. I'm interested to know, with the multidisciplinary approach that could exist or we would like to exist, you could answer it either way. How do you all bring people together, and how can that inform diagnostics in the future?
Yeah, I think, certainly one piece that has been missing is the involvement of patients. I think a lot of times testing has been very prescriptive from the point of view of data that is most meaningful for providers and what we think of as being highest risk. And so originally that was the later risk of type 2 diabetes that set the diagnostic criteria that we're still using. And then we became a little bit more thoughtful and then thought about pregnancy related outcomes and started thinking along those lines. And so I think that's one aspect of it. I certainly think having an individual with a background in nutrition and being able to provide nutritional advice and someone who oftentimes has a title of a certified diabetes educator is very helpful because they can provide the duality of nutritional counseling, feedback to the patient, as well as assistance with interpretation of blood sugar data that they're providing and potential anticipation. And so one of the things to potentially go back to your earlier questions, one of the ways I would that I have sometimes had conversations with patients about is to think through their menu and their eating habits because nutrition is really the mainstay of treatment in most patients who have gestational diabetes. And in that setting, some of the times, some of the advice that we provide for them is to say, you had 4 bananas last week, and every time you had a banana, you spiked the blood sugar. And so maybe now you should have a smaller banana, or maybe think about another fruit. And so thinking along the lines of automation and leveraging AI capacity, that would be one of the things that I would potentially also think of as being at the individual level to help guide kind of menu development or nutritional advice at an individual level by using data that was collected from a patient, even though it was a week old, to sort of understand what their patterns of response to certain dietary habits are, and then to provide potentially alternatives, including menu planning and serving sizes to help guide their intake.
Yeah. There's been a lot of in the Q&A some discussion about nutrition, the role of nutrition, how important it is. So I'm really glad that you brought that up and highlighted that here. Um, Another question that's in the Q&A that I think is relevant and kind of draws from this is, what are some things or strategies that can help lower the chance of GDM? I think somebody here said that they know that eating less sugar theoretically is one of those things, but it's a hard change to make for patients.
It is. It is a hard change and it's hard to sustain it. And in general, it's challenging because even if you change your diet for a few weeks in pregnancy, it may not be enough to be able to significantly impact your metabolism and to be able to drastically kind of change your risk profile away from a high likelihood of having a diagnosis of GDM. We know that, there's data to suggest that if you change your carbohydrate intake, in the US, what ends up happening is you end up increasing your lipid and your fat intake, specifically your saturated fat intake, because most of the options that are provided that have a lower carbohydrate intake make that switch from sugars to saturated fats. And so I would caution I would not encourage a strategy of low carbohydrate intake in the setting of pregnancy because generally speaking, ultimately, saturated fats are likely to certainly have double the amount of calories compared to a gram for gram comparison with carbohydrates. And we know that ultimately any excessive caloric intake is still going to lead to increasing in a pathway towards gestational diabetes, whether the entry point is through excessive carbohydrates or switching that out to saturated fats.
Yeah. I'm curious to know because it's Diabetes Awareness Month, and we're a big proponent here of making sure that people have access to education and making sure that they understand the variety that exists within diseases and conditions. But somebody asked, how does treating GDM change compared to treating an individual who is recently diagnosed with type 1 diabetes, and what makes the gestational aspect more challenging?
Yeah, that's a really good question. And that's actually a hard framework shift that we ask patients to, even patients who have diabetes, to change their thought about their disease during pregnancy. The big difference is the timeline. When we're talking about type 1, type 2 diabetes, and we're talking about complications, we're talking about risks that are 5, 10, 20 years down the line. And so there is time for interventions to be tried. There is an opportunity to quote unquote, not respond or fail a treatment, try something else, try again before you are impacted by the outcome of interest. In pregnancy, when we're talking about diagnosing individuals, we start screening at 24 weeks. Most patients on average are diagnosed between 26 and 28 weeks. And if on average, patients who are pregnant with a single baby will deliver at 37 weeks. So we are talking about a timeline of 6 to 10 weeks on average between diagnosis and delivery. And that is very, very challenging because it is very hard at this point to be able to significantly impact things in a positive way when you have such a short timeline. It's also very hard for patients because they're going from having a quote unquote normal pregnancy to being considered high risk and to be willing to accept all those extra interventions, which are recommended at this point and are recommended equally, even though we're not able to be able to stratify risk in even a subgroup way. We sort of prescribe testing to everyone. We exhaust everyone with extra appointments. Sometimes we recommend early delivery, and it's just very prescriptive, and it's the same across the board, just given that diagnosis. And so it's very, very hard. And you might be thinking, well, why don't we screen earlier? And why don't we think about doing things at an earlier point? And those were exactly thoughts that have happened over the past few years. And there have been attempts to look at screening earlier in pregnancy. And unfortunately, those have not really panned out in the way we've expected. And what I mean by that is we were surprised that outcomes really didn't improve. We picked up more patients with hyperglycemia even earlier on in pregnancy, and we treated them with more medications, including injectable medications, at quite a significant personal burden and personal cost. But the outcomes were not different, even in research study settings. And that has been a source of a lot of confusion. And the take home for me has been, again, when we focus on glucose and all we're doing is shifting the line, whether we're shifting the line of lower thresholds or shifting the line to earlier testing, that does not seem to be enough. And we have to think of alternative ways.
Yeah. Well, thank you for that. Before we wrap up, we have one last question. We have a diverse audience spanning patients and healthcare providers, researchers, industry, policy professionals. So, if you were to have some lasting words, what is one key takeaway that you would like to emphasize to everyone?
I think even though I have been potentially very critical of the testing and the diagnostic and the predictive approaches that we have for GDM. I think one message that I would like to communicate is that gestational diabetes testing is very informative. Knowing that someone has gestational diabetes is of significant potential benefit, like just the knowledge alone, to understanding the long-term risk related to the pregnant individual as well as to their offspring. And so even in the absence of very strong capacity to predict risk at an individual level, I think it's still important to try to investigate and try to understand if there are better approaches to engage during pregnancy and longer term, because I think part of the reason why the incidence keeps going up so much is that there's this transgenerational effect that we are not, this loop that we're not able to break at this point. We are able to identify but not break the loop because of the significant impact that this condition has on the pregnant individual as well as their offspring. And so while the current approaches are very limited, the knowledge of gestational diabetes and engaging with this patient population, I think, is very, very important to try to address these long-term risks at the level of the population.
Wonderfully said. And I think with that, we will close our Q&A session. But again, thank you to Dr. Fagali for your time and insights, and to Roche Diagnostics for their support of this public forum and SWHR's value of diagnostics within Women's Health series. We thank everyone in the audience for joining SWHR during our diagnostic series to highlight various areas of women's health and that benefit from innovations in screening and diagnostics. And we invite you to visit our website, www.swhr.org, to watch the recording from this entire series of public forums. Understanding women's individual experiences and health journeys help us inform healthcare systems and policymakers on critical gaps and specific areas of need in women's health. SWHR invites you to share your story about maternal health, fertility, heart health, autoimmune disease, or another women's health topic by visiting www.swhr.org/share-your-story. And we should be posting the link shortly. In addition to our website, you can also connect with us on social media to register for future events, download women's health resources, and to sign up for our newsletter. We will send out an email with a recording of today's webinar to all registrants, as well as post the recording on the events webpage for future viewing. So please be on the lookout for that and feel free to share with others. As we continue the conversation with hashtag SWHR Talks Diagnostics and hashtag SWHR Talks Maternal Health. Thank you for joining us.